All right, ladies and gentlemen, welcome to this live demonstrations on various modalities. Which we are going to talk today is about mitral stenosis, aortic stenosis, mitral regurg, aortic regurg, pulmonic and tricuspid stenosis as much as possible. I'll get going with a live demonstration, picking up cases from a machine directly. And I'll ask a few questions from the delegate itself, like how do we really look for these features? Let me share my machines first of all. I hope all of you can see my screen. Anyone can open up and tell me?
Yes, sir.
Okay, all right. So the first question goes to Dr. Balram. Dr. Balram, are you there?
Yes, sir.
Balram, tell me what exactly do you look for a mitral stenosis?
Well, with mitral stenosis,
Right.
the first thing I would look for is dilation of the left atrium.
All right.
So after we do the 2D, then we can do the colors. And if you do the colors, you can see a jet wave going through from the atrium to the ventricle.
All right.
And once we do Dopplers, we can measure the.
So Dr. Balram said the first thing we often see in mitral stenosis is dilated left atrium. Is everybody comfortable with them?
No,
I'm not
That is one
comfortable
of
with
the
this question.
That is one of the things to be looked for.
It is one of the things to be looked for. What is the most important characteristic feature for a mitral stenosis we should look for and where we should look for?
Sir, it is the ballooning of the valve, sir.
Not ballooning of the
Anatomical
valve,
Doming.
elbowing.
doming of the valve. Exactly, it's a doming of the valve. Look, this valve, it domes. What do you mean by doming?
Convexity toward distal chamber.
Convexity towards distal chamber, and we can say in simple language, hockey stick shape of mitral valve. Look, I'm trying to freeze that frame over there. This is like hockey stick shape of the mitral valve. And why this doming happens?
Because of thickening.
Commissural fusion.
Thickening, commissural. What commissural thickening? Commissural thing. What is to do with the commissures and thickening with the doming?
Commissural fusion.
Commissural fusion. Commissural fusion will reduce the space, not the doming.
Sir, what happens is actually, sir, huge amount of blood accumulates and it cannot go through the valve.
No. You know why this doming happens? This is a characteristic feature of a rheumatic heart disease. When the patient develops a rheumatic fever, there's an inflammation of the valve as well as the cords. Correct? Then we have two types of a cord, primary cord and the secondary cords. Primary cords are attached to the tip of leaflets. Secondary cords are attached to the body of the leaflets. Right? When infection happens, they get swelled up. And initially, all the patients are present with rheumatic mitral regurgitation. We have not seen acute rheumatic valvulitis as patient presenting with regurgitations. So when these lesion heals up, the secondary cords become smaller as compared to primary cords, and these stretching of the leaflets of these secondary cords leads to a doming of the leaflets of the mitral valve. And this doming is not found in any other conditions. And what we say number of times is a hockey shaped structure. Now you can see this slide running. Second is thickening of the leaflets. The tip of the leaflets, they are thickened. I'm going to show the thickening of the leaflets. This is opening in mitral valve, and we can measure the thickening of these tips. How do we measure the thickening? At the tip of the leaflets, we measure it should be more than 5 millimeters in thickening. It's 0.8. 2. Third, when these primary or secondary cords, they are not able to open completely, what will happen to the mitral valve opening? And this is known as mitral valve cusp separation in Plaque's window. So let's go and see how much is the cusp separation in this window is. I'm going to stop this frame. Take by frame by frame, and let's see how much it opens up, maximum. So this is maximum it's opening up, and I can take a caliper and measure it straight forward. It's the distance between two leaflet cusp is almost 0.6 or 0.5 or 0.6 centimeters or 5 or 6 centimeters. First point, thickening, hockey shaped structures. Then the cusp separation between AML and PML is about 10 or like anything between 6 to 10 or 12. One of our own colleague back in Vellore, he categorically published one paper at one time is if the cusp separation is less than 6 millimeters or 5 millimeters, we always consider these people having a severe mitral stenosis. We are not going to talk about all that because we need a quantitative data for looking at mitral stenosis. Is that right? Let's go to next person after Balram. Balram, you were correct, but not to the large extent. So your first answer should have been, rather than talking about dilated LA, LA may or may not be dilated. It all depends how long this issue is going on, whether it is associated with mitral stenosis, is associated with regurgitation or not.
Yes, sir.
Higher the regurgitation, more the chances of having a dilated LA, right?
Yes, sir.
All right, let's move to the next person. What's his next person name is? Just give me a second. I'll just bring out his name. Spend time. You cannot get a better interactive sessions than this. I can only tell you this. So online programs. All right, Dr. Vasudev Utpat.
Yes, sir. Good evening.
What is the next feature of mitral stenosis, Vasudev?
In the same flax view, we can go for M mode, in which we can see the AML and PML moving in the same direction, as well as the D excursion will be going down. And
great, good answer. M mode and these things going in the same directions. What Dr. Utpat says. All right, let's see whether he's right or wrong. So I'm going to take a caliper. First of all, I'll take an M mode. Take my M mode line. So what Dr. Utpat says is correct to a large extent. Let's spend time why it's correct. Look, this is, I'll just make it a little better. So this is AML and here is a PML. Both the leaflets, they're going in the same direction. Normally what happens, AML will go like this, PML will go like this. So they'll be opening in one direction, this will be opening in another direction. So movement of both the leaflets in the same direction, which against tell you possibly these things are happening because of mitral stenosis. Good, Utpat, that answer was pretty nice. Let me go to the third person now. Dr. Tushar. Dr. Tushar, are you there? This is not good, you know. Dr. Tushar, if you are absent, that doesn't look nice, you know. Fourth is Dr. Tiam. Dr.
Yes.
Tiam, are you there? Tell me the next
yes.
feature of Tiam.
Yes.
I know you are there, yes. But Manik, tell me the next, what else you look for mitral stenosis?
I look the fusion of the commission.
Fusion of the commissions. Okay.
Yes.
So he's asking for a fusion of commission. How do we say a fusion of a commission is? We go to plaque short axis view at Where? At mitral valve levels. So I have to go down to a mitral valve levels to look for a fusion of commissures.
Yes. Yes.
So let me get rid of this measurements. Yeah. So what does it says that this is AML, this is PML, this is lateral commissure, this is medial commissure.
Yes.
There's thickening and fusion of these commissures, which could be a feature for mitral stenosis. Correct? No doubt
Yes.
about it. It is there already. So we look at this thickening of or fusion of these commissures. What else, Baniki?
I see it is there is a fusion commission.
There's a fusion of commissure is there, right? What else?
The lateral, I think.
No, tell me other features of mitral stenosis.
Yes.
We saw the fusion of commissure is there, and we look at fusion of commissure at parasol long short axis view at mitral valve.
Yes.
Okay. Let me go to the fifth person now. Dr. Krishna Yadav. Not Krishna Yadav. Dr. Ghanshyam Motisaria.
Yes, sir.
Tell me the next feature of mitral stenosis.
There will be thickening of leaflet.
We have already done. Thickening is
Okay,
done.
restriction
Mitral
of-
cusp separation is done. Commissure
Then-
thickening is done. Dilated LA is done. The motion of AML and PML, they are not in same,
Paradoxical motion.
reciprocal direction.
Okay.
They are in same direction. What else?
Then else mosaic color pattern
Okay. He now says mosaic color pattern where?
at the level of stenosis.
In which view?
In apical four chamber.
All right, good. He says
Uh,
we'll see a mosaic color pattern in apical four chamber. So can you see the mosaic pattern?
Yes, sir.
What do you mean by mosaic pattern?
There is a lot of different color.
This is known as turbulence.
Turbulence. Yes.
Look, the word is turbulence is related to CFM, color flow mapping. And when we have a turbulence, our color towards the translucent is always red, away is blue. So we see a lot of turbulence across this mitral valve. And not only this turbulence, what else do you see in this mitral valve? There is thickening of
Thickening.
leaflets, restriction of cusp motion. What else?
Jet area.
We have not come to jet area as said. You said
Then
color flow
like-
mapping mosaic pattern is there. Fine. So let's move on to the next person. Dr. Damodar Swapnil. Damodar, are you there?
Yes, sir. Good evening, sir.
Good evening. Tell me.
So, there was in Plaques view, sir, we will be seeing the
What we have
restricted
covered,
motion
we are
of
not
the-
going to talk about that. Let's tell me what else you see apart from what we have covered.
So when we put
What
the
do you see
color
in four-chamber view?
in four chamber view, there will be enlarged left atrium
Okay.
and enlarged right atrium. This right ventricle also could be there's a tricuspid regurgitation.
Gentlemen,
mosaic pattern at the mitral valve.
let's cover the proper topic first. I'm showing you a slide. What else you should do in this slide now?
Recording in progress.
So there will be enlargement of the enlargement of the left.
Now let me see.
Hypertrophy.
No. What's next is we should put a continuous wave Doppler across this line of a blood flow. Let's try to do that if it's possible. Controls. Smiled MR is present. So what we do, we put a continuous wave Doppler across this. First we will put a pulse wave Doppler. Then we put a continuous wave Doppler across it, and what we get is a mitral flow pattern. So, Dr. Swapnil, what kind of a mitral flow pattern it is? Do you see something in this flow? 1 is 2, 3, and 4.
So E and the A wave.
E. There is no
The
A
E-
wave. There is no
there-
A wave. There is only E wave which is present over here.
So we have
What do
to
you-
see the deceleration time, sir, and
All right.
we have to trace the area under that wave.
Now, let me just complete
It's
it
a
up.
PhD, sir.
Yeah, what we're going to do
PhD.
is, this is an atrial fibrillation. We do not have any A wave. So we see a Doppler flow pattern across this mitral valve by continuous wave Doppler. Do you see this continuous wave Doppler across it? Then we trace this Doppler spectrum pattern from top and came down to bottom. Now we see a peak velocity of 1.37, mean velocity of 0.91, peak gradient of 7.5, mean gradient of 3.65 with VTI of 53.6, and then we took a peak to bottom that gave me a pressure half time of 2.19 and a mitral area based on pressure half time which we got 1 centimeter square. So
Yes,
if it's atrial fibrillation, we are not going to take that, we do not have A wave. So we'll just trace the
We have
Doppler
to take
spectrum
minimum
pattern
5 readings.
and we'll take these kind of at least 5 readings. What we'll do with this reading? From where we'll measure this? Next person after Dr. Swapnil, there is Dr. Rahul Kenkan.
Sir, we can look at the mean gradient to grade mitral stenosis.
We already did that. I'm asking you a question. Look, from where I should do it. Let me just measure this pattern over here.
Sir, we'll measure the slope to find the pressure half time.
Wait a minute. Now you tell me where to go. I'm going to measure all this in front of you. Mitral valve. I'm going to trace the mitral valve. And now I'm going to trace this mitral valve from here. Go all the way up. Now should I go up like this? Come back over here, then drop myself over here, right? Is that correct, right, or wrong? Rahul.
Sir, we have to trace the linear slope, like.
So what we should do in this patient is, we can trace this. It will give you a peak and mean velocity, peak gradient, mean gradients. But when we take a pressure half time in this patient, we do not take this. We take the, get rid of the upper notch and we'll trace like this a pressure half time.
Yes, sir.
Is that everybody clear about this?
Yes, sir.
Yes.
Mitral area by pressure half time now is 0.8 centimeter square. This was 1. This is 0.8. So we do the same thing in multiple, at least 5 sample volumes. And then we take an average of pressure half time, area, and we get a peak and mean gradients with this. Is that okay?
Yes, sir.
Now the next question comes to Dr. Krishna Yadav. Dr. Krishna Yadav, are you there? Mrs. Jigna Viresh. Jigna?
Yes, sir. Yes, sir. Good evening, sir.
Good evening, Jigna.
Yes.
Tell me, you got a 5 of these sample volumes. Everybody is talking of 0.8, 0.9, 1, 1.2, 1.3. How do you say what is the area of these patients of mitral stenosis?
So first we'll check by planimetry
All right.
in mitral valve at the level of mitral valve, short axis level. We'll measure we'll trace the mitral valve area. If it is less than 1, it is severe.
Very severe, not
Very
severe,
severe.
very severe.
Yeah, 1 to
2014 guidelines, Dr. Prasha said very categorically, 1 to 1.5 is severe, less than 1 is very severe.
Yes, sir.
And after 1.5 is progressive mitral stenosis.
Yes, sir. And we'll check.
My question is, you have got 5 of these readings. So how will you say what is the area of this patient by pressure half time?
We'll take average of 5.
Right. You are not going
Yes.
to take, you are going to take average. You are not going
Yes,
to take
sir.
the maximum or the minimum.
Yes,
So that's
sir.
what the difference in other subjectors.
Yes,
But
sir.
in atrial fibrillation, there will be a discrepancy among all these values. So take an average. Then
Yes, sir.
as she said, we should go to parasternal short axis view at aorta. Sorry, parasternal short axis view at the tip of the mitral valve
Mitral.
leaflets.
Yes.
Jigna, you have been doing a lot of work. Tell me, how do you get to the best mitral valve area in parasternal short axis view?
Sir, first we'll take papillary muscle at the level
Great,
of papillary
wonderful,
muscle, and
Jigna.
then
God bless you.
yeah, yes, sir.
So she'll
And
take
then
papillary muscle first.
and yeah, sir. So then we'll tilt it, then we'll go one like what I say, we'll take papillary muscle view, and then we'll tilt probe, and then when we get the first mitral valve, that
That'll be the
round.
tips.
Yes, sir. That will take.
So everybody is clear what she's saying?
Yes, sir.
In parasternal
Yes, sir.
short axis view, what we'll do is we are going to go to first papillary muscles, and from papillary muscle we'll go towards mitral valve. And whenever you come across the first circular line, that will be the mitral valve area at tips. This thing has been modified to a large extent by newer machines. This is multi-dimension, 3D MD 3D transthoracic echo. What does this MD 3D transthoracic echo does, and I'm sure it's going to come in many machines in time to come, is we see this window, we have this plaques view. We'll do a cursor over here at this particular point. We are cutting it right at the tips of the mitral valve leaflets. And when we are cutting the right tip of the mitral valve leaflets, we see what is this area is. So we don't go blindly, we go thoroughly, like look, we are doing at the tip of the mitral valve leaflets. Is that clear?
Yes.
So we'll go from parasternal short axis view. We'll go from plaques window to short axis view, and from short axis view we'll go to papillary muscle. From papillary muscle we go towards mitral valve, and as soon as we reach mitral valve, the mitral valve will give us a mitral valve area. All right. Now next question goes to, and I request everybody, please silent your mic, or else my colleague, she's sitting on other side. She'll just silent your mic also, and if you not listen, she'll shunt you out also. Somebody's mic is open completely and somebody is shouting loudly. Dr. Ranjit Shankar.
Yes, sir.
Dr. Ranjit, what else you look for mitral stenosis?
Donc voilà, et puis alors la prochaine partie, je vais faire, on va d'abord étudier, c'est bien. C'est dommage que la partie.
We have checked, sir, area by pressure of time and area by planimetry.
We have already done that.
Yes.
We look for tricuspid regurgitation now.
Okay.
As somebody said in the beginning,
Yes, sir.
so we start looking for a tricuspid regurgitations. So what do we look for tricuspid regurgitation is? Evidence of raised pulmonary artery pressures.
Okay.
Look, this is the TR jet.
Yes, sir.
The vena contractor is 1.06. And you know what is the gradient across this is? 2.423. Approximately, we should expect a gradient of 30 millimeters of mercury, peak gradient in severe aortic stenosis.
तिला घेऊन जा नानाकडे मम्मीला घेऊन ये मी खाली नाना बोलो अबे
कसा आहे रे तू?
All right. So let's comprise the features for mitral stenosis. So I am going to show you all the slides one by one now. Dilated LA, cusp separation 0.6. LV size should be almost normal. Is 32 is 30. Then thickened calcified mitral valve leaflet with restriction of cusp motion, doming of AML because of thickening of secondary cords. The distance is almost reduced for opening. Then short axis view at papillary muscles. Pulmonic flow velocity is normal just to rule out any stenosis. And if you look at a color jet, this is in a flow velocity across this color jet. Nothing to do at your level. Forget about it. Then this is mitral area by planimetry. It's 0.1.99. We are going to do it again because we couldn't see this particular medial papillary muscle and lateral papillary muscles together. Then next is pulmonic flow velocity, again normal. And now we have got a flow across this mitral wall. And this is an atrial fibrillation. We do not have any atrial kick. If it's atrial kick, we'll measure the atrial kick also at the same time. And in atrial fibrillation, we are going to measure this 5 of these sample volumes. This will give us a peak velocity, mean velocity, peak gradient, mean gradient, and the pressure half time area by this thing, mitral flow patterns. And in this, it's 0.97. So with this, it is very severe, but we don't buy this because it's a mitral stenosis. Then we have done measuring many of values to come to a conclusion. Look, it's 0.1, now is 1. Small trivial regurgitation. Again, a Doppler spectrum pattern for 1. This is same, 0.98. 0.91. Now you can see whenever we are doing in a lab, we are doing multiple values, 0.96. Now is the aortic flow velocity just to rule out any stenosis. This is tricuspid flow velocity, E wave. We do not have any A wave also. And this is TR jet gradient of 2.1418. We were not happy. We went back again to measure it. That's come out to be almost 2.4. And we spend number of times to come to a conclusions of maximum gradient. We don't take average. Now we take the maximum gradients. This is E prime septal, E prime RV free wall, and then LV function in toto, because majority of these people, they have an LV function, which is low normal because of poor blood inflow from atria to ventricle. And you can see a very good spontaneous echo contrast over here. All of you can see this. Anybody can open their mic and tell me.
Yes, sir.
Yes, sir.
This is a very good spontaneous echo contrast, which is seen over here. And whenever you see all this, we try to look for we measure the annulus. This is again not at your levels. Annulus in 4 chamber and 2 chambers. And then this is the atrial appendage. We try to look at the atrial appendages. Because when we have a contrast in this thing, this is annulus at the measurement of 2 chamber level. 3 chamber LV functions. Zoomed up picture. Same. We are trying to look at some thrombus or clot in left atrial appendage. There are very high chances of having a thrombus and clot. 3 chamber again. Then we go to subcostal window. And this is a very interesting finding. I'll come back to you. IVC is dilated. This is approximately a 3-dimension echocardiography. And look in this 3-dimension echocardiography, what is happening to interatrial septum? it's bulging towards right side, suggesting that LA pressures are very high in comparison to RA pressures. And this thing is seen in a very good format once you are doing a subcostal window. Look, this is a bulging of interatrial septum. Now you can see this is tricuspid valve and this is interatrial septum bulging like this. This is not a thrombus. This is not something else. This is just a bulging of interatrial septum from LA, and this is interatrial septum which is bulging towards RA, and this is tricuspid valve in subcostal window. Lot of sketch. Now we are concentrating on LA appendage again and again. Now this is, we have opened up left atrial appendage in this patient. You can see the contrast seen over here, spontaneous echo contrast, but there is no thrombus, looks to be in the 3 dimensions transthoracic echo. And now this is to a large extent what we confirm is this is 0.78, this is multi-dimension 3D, and this is 0.68, and this is 1.76. Now, if you look at this 1.76, we are not cutting at the tip of the mitral valve leaflets. We are way away from that. So, what we see in mitral stenosis in live demonstration is anybody would like to volunteer and tell me what all you they see in live demonstration now? Identify yourself and let me know.
Hello, sir.
Yeah, go ahead.
In mitral stenosis, we are looking for doming,
Right,
then paradoxical movement of PML,
correct,
thickening of leaflet,
right,
restricted movement,
right,
restricted opening,
right.
enlargement of left atrium,
Okay,
and mosaic color pattern,
okay.
color flow.
That's all. Mrs.
Yeah.
Yeah, go ahead.
Here,
Area is dilated. Then we also see the any spontaneous echo contrast.
Okay.
tricuspid
Then we
regurgitation
also
by measuring.
see the tricuspid regurgitation.
Gentlemen, you are talking of everything except for the flow velocity across this mitral valve. You have to have a peak and mean gradients which are high. You have to have a pressure half time which is increased, and then radii is reduced. This is what the most important quantitative measurements. So we look at a flow velocity across this mitral valve, put a continuous wave Doppler across it, and then we evaluate the Doppler flow pattern, trace it to get a peak and mean gradients as well as mitral valve area pressure half time. To correlate this mitral valve area with pressure half time is we go to planimetry in parasternal short axis view at papillary muscles going towards mitral valve. And if this area is less than 1 centimeter square, we call them as very severe. If it's between 1 to 1.5, we call them as severe. And more than 1.5, we call them as progressive mitral stenosis, right?
Yes.
So the most important part is mitral stenosis, remember, is planimetry as well as the gradients. Okay. So Jayanti, what are the gradients for a severe mitral stenosis?
Planimetry below 1.
Right.
And PHT pressure half time is also.
We don't measure pressure half time. We get area by pressure half time. I'm asking you at what gradient level you will say is a severe mitral stenosis?
More than 10.
More than 12.
More than 12 is ideal one. The majority of people, they say more than 12, which is peak or mean.
Mean gradient.
It's a mean gradient. Remember a basic principle. If it's pulmonic, it's peak. That goes for P to P. If it's mitral, is mean. Okay. So any gradient more than 12 millimeters of mercury, which goes to severe mitral stenosis. Area less than 1 is very severe. 1 to 1.5 by planimetry is severe. Then along with this, patient should have a TRZ gradient of more than 30 millimeters of mercury to call them as severe mitral stenosis. Is that okay now for mitral stenosis? Any question? Somebody can open up mic and I explain mitral stenosis again.
Sir, if patient in sinus rhythm, then how will we get the CW trace signal? Mitral signal, sir.
If patient is, his question is, patient is in mitral stenosis with NSR. Is that right? Is that your question, dear?
My question is, sir, if patient is sinus rhythm, then how we will get the CW mitral signals?
All right,
How will...
I'm going to show you that. I'm just asking you, that is your question is, I showed you atrial fibrillation. He said, I want to see now a regular mitral stenosis. Correct?
Yes, sir. Right, sir.
Let me look at it, regular mitral stenosis. Good. I liked it because he has got a, like, he's thinking right now, like, how does it happens? So I should be able to look for a mitral stenosis with NSR, normal sinus rhythm.
Okay.
It looks like today is a day for atrial fibrillation, but there should be one. No, even this is atrial fibrillation. So let me go to my archive again. All right, I'm not able to find, but I'll give you an answer. Let me pick up some other slide. All right. So
Yes.
this is what, if it's a normal sinus rhythm, what will happen? We'll get this kind of a pattern in NSR, right?
Yes, right, sir.
So I'm going to measure my Doppler flow pattern in this. Let me go to mitral valve. Let me trace my mitral valve. I'm going to do like this. All right. So once we trace all this, we get what we get: peak velocity, mean velocity, peak gradient, mean gradient. And now with the pressure half time, I'm going to get the mitral valve area. My mitral valve area and this by pressure half time is 3.2 centimeters square. So in case of a stenosis with a normal sinus rhythm, you'll find the same thing. Is that clear?
Thank you, sir. Yes, sir. Thank you, sir.
Okay, then. Anybody else? Some question on MS?
Sir, this is Nida.
Smita, go ahead. Nida, go
Sir,
ahead.
yes, sir. Can you comment on mitral restenosis, sir?
Can I comment on mitral restenosis? Yes, I can
Yes.
comment on mitral restenosis. What exactly happens when we open up this do with commissurotomy by balloon? These commissures over a period of time, they again get stenosis. They get thickened, and because of thickening, the mitral area becomes again reduced. So it's very difficult number of times to talk of restenosis unless until we have an existing history that patient's CMV or BMV was done at one time. Let me just give me a second. Let me find out a name. She was, I hope I have downloaded her in the system. The presentation will be almost the same as in normal subjects, as in mitral stenosis. She was Komal Rajgopal. Oh, you got it. This is a lady who CMV was done, not BMV. It was a CMV which was done. What is CMV?
Closed mitral commissurectomy, sir. It was
Closed
done.
mitral valvotomy or commissurotomy. And how do we do this closed mitral valvotomy or commissurotomy?
Thoracotomy, sir.
It's a very crude way of doing it. Open up a chest, open up the mitral valve, not open up the mitral valve, open up the LA and put a finger into this mitral valve to open up the valves. Like what we used to do with, now we are doing with balloons. We were doing at one time, putting our fingers into the mitral valve to dilate them. This is known as closed mitral valvotomy. It's not being done anymore now. So Nida asked this question. Now, Nida, you can ask me, this is the same patient who was done a closed mitral valvotomy as one time, and now she's back again with us with stenotic level now. If you can see this stenosis again, it is very difficult to talk of a stenosis unless until we have a previous existing history. And this lady, with this, I can just show you a mitral. Somebody was asking in normal sinus rhythm. So you got this normal sinus rhythm now. This lady is in normal sinus rhythm. You see a tall E, small a wave. So I'm going to measure this tall E, small a wave. And I'm going to go to mitral valve, trace it up. So this is how I'm going to go and trace this lady. You should pay thanks to Nida, because Nida asked this question and that's how we got it. So this is a correct measurement of mitral area by pressure half time, which is 0.9. I'll just show you what are our area by balloon, by planimeter. So look at our gradients. Gradients are 6. Mean gradient are 6. Anything at least 12 should be a very high gradient. So she's in progressive mitral stenosis. Let's look at a mitral area by planimeter. Look, this is what I was saying. Again, a picture which I was trying to show you. Now we are seeing a 2-dimensional pictures in one go. Right now, I'm the tip of the mitral valve leaflet. I can see both my AML, both my PML, lateral commission, and the medial commission also. This you have to do by going from parasternal short axis view and then coming back to tip of the mitral valve leaflets. Here is papillary muscles. So once you come in short axis view from papillary muscle to the mitral valve leaflets, the first you will come across the tips, and there the tips are. And once we measure this, that will give an exact idea how much is my mitral valve area by a planimeter. Is 0.92. So but we do it again and again. Even here I'm not comfortable what exactly the mitral valve area is, because the gradients are only 6 or 7. So I have to do it multiple times before. Even here also I'm not comfortable because I have to get the best possible mitral valve area. 0.92. And she has got at least moderate degree of mitral regurgitation now. Why this moderate degree of mitral regurgitation, Nida?
Sir, because of the AML tears, sir.
Not AML tear. AML tear will never happen.
Sorry.
When we do this blind procedure is, we do it over dilatation. And when we do over dilatation, there is a potential gap between two leaflets to give you a mitral regurgitation. And that is why whatever the BMV or CMV we were doing, we do not have any mitral regurgitation before they take up these people. And there should not be calcium on the commissures to take up these people for commissurotomy by the balloon or closed. Is that questions clear for mitral stenosis?
Yes.
Anybody else?
Good evening, sir.
Good evening.
Yes, sir. Dr. Samrat here. Sir, I had just one query, sir. How to differentiate between vegetations and, sir, mitral wall thickening, sir?
Vegetations are healed lesions. And if you ask me, you cannot differentiate them. Only the vegetations, if they are active, they are being detected by T-score of the CT scan.
Yes, sir.
That you remember that thrombus versus vegetations?
Right,
Even
sir, yes.
these vegetations, even if this is vegetation, earlier what exactly? Rheumatic nodules are vegetations basically.
Yes, sir.
And when they heal, they look alike.
Yes, sir.
So we cannot differentiate vegetations, healed vegetation with thickening.
Yes, sir. Thank you, sir.
Thank you.
Sir, Dr. Vasudev here.
Hello. Yeah, Vasudev.
Sir, like in this post CMV, when we are not getting area exactly, because we have 3D, we are actually seeing at what level we are taking the area. But if we don't have that facility and area is coming more than 1, but the gradient is less, like borderline 8 to 10. So whether we nominate it as a severe or progressive?
Very good question. What exactly happens? But I'll put up these people for a clinical aspects, whether they are dyspneic, symptomatic or not. And if I'm not really sure what exactly we are dealing with, I put a transesophageal probe inside and look for an exact area. This lady, we did not give any significance when we saw normal sinus rhythm. Imagine somebody who's carrying a normal sinus rhythm, the chances of having a dyspnea or like symptomatic is pretty less.
Okay, sir. Okay,
and let's look at this pressure halftime in this patient over here. The last is very good imaging quality. This is a very good Doppler graph. This is almost 1. So this patient was absolutely asymptomatic. We did not do anything with her because her gradient were about 5 to 6. She had a prior history of a closed mitral valvotomy. And we do understand in these patients, somebody who asked this question was, we do understand in these subset of population, we are not able to measure the correct areas by planimetry. Why? Because the previous surgery has done a damage to both the commissures and other things. So a lot of things they happen, like a lot of calcium they have, and then we go by these gradients to look for this is like this is severe, very severe, or progressive.
Okay, thank you.
Right. All right, let me stop over here. and then
Sir,
I'll go
sir,
to,
one more question.
yeah, go ahead.
Sir, sir, can you show this commissural fusion and normal commissures?
Can I show you
difference.
commissure fusion with normal commissures? Great. I'll be able to show you. Before I show a commissure fusion and normal commissures, look, this is splitting of commissures. Can you see the gap over here?
Yes, sir.
This is splitting of medial, this is splitting of lateral commissures.
Okay.
Is that clear now? Let me now
Yes,
go to severe mitral stenosis and atrial fibrillation. All right. Now, this is what the image is, parasol short axis view at mitral valve. Look, there's small thickening of medial, lateral as well as medial commissures. You can see this commissures which are not really thickened. There is some speck of calcium present on these commissures,
65
whether lateral or medial.
100 could be 65.
Yes, sir.
Please silent your mic. I'm still requesting you, please silent your mic. There is no harm in silencing your mic. Otherwise, I'm going to find out, and then I'm sorry to say that. So these are not thickening. They are normal commissure with some specks of calcium in it. So this is one. Let's go to some other mitral stenosis.
Small bottle. Oh, two I bought. Again, I bought 2 things also. See, this thing I missed now, class 8 o'clock.
Oh, damn. It starts at 8 o'clock, right?
Here, I'll keep my car outside.
I'm sorry, I have no answers but to just shunt them out. All right. Now you got it very clearly.
Okay, sir.
Now this is thickening. I showed you one which was not thickened. Now this is classically thickening. Both the sides. And this has got a calcium on top of it.
Okay. Sir, is there there will not be any gap between these two?
If the gap is there, it means the commissure have been splitted. That post commissurotomy. Otherwise, why you will have a gap in commissures?
Okay.
Is that right?
Yes, sir. And then what is the normal view? Can you show that normal?
I showed you normal a little bit earlier. Okay, I'll show you in some other patient. Just give me a second. Tell me what to do with these kids now. The kids does not have any role. This the parents have the role. You know, they can't silence their mics. All right. Can you see this this thing? I'll just zoom it for you. Can you see these commissures over here? The lateral one and the medial one over here.
Yes,
they are not
sir.
thickened.
Okay.
How do you say that they are thickening or not thickening? You look at the AML, you look at the PMLs. You look at the surrounding tissue. This is the interventricular septum. You look at the surrounding tissue. The echogenicity of the tissue and the echogenicity of the valve should be almost the same.
Okay, sir.
All right?
Okay, sir.
All right. So from here, yeah, go ahead.
So by echo, can we say that the patient has gone through BMV?
No, We can say sometime. I'm not saying 100%.
In
Definitely,
report,
we can
they
say when
sometimes
there's a
write
commissural
report.
splitting is there, we always say that patient has got a BMV or CMV.
And so it should be written in the report.
Fresh report or the older report?
Sir, a de novo patient has come. He is giving a history that he went.
Yeah,
Sir,
you
can you
can
hear me,
write.
sir?
If you find a splitting, you can say that.
Okay. Okay, sir. Fine.
Right.
Sir, one question.
Go ahead.
Sir, how to differentiate between like a blob of calcium and a vegetation?
Echo wise?
Yes, sir.
No, it's not possible.
Okay, sir.
So, all right, let me move on to aortic stenosis from mitral stenosis. Dr. Ranjit Moite. Ranjit, are you there?
Yes, sir.
Tell me the feature for aortic stenosis, Ranjit. You can't, Ranjit? All right. Dr. Bhatkar.
Sir, good evening, sir.
Good evening. Tell me features for aortic stenosis.
Sir, in aortic stenosis also we will get the thickening of the cusps and their motion will be less. Then we will measure their area in aortic wall area. Then gradient, we can measure the gradient with.
Okay, let's say one by one. Thickening would be seen in which view? Mitral, plaques, apical?
Sir, in plaques we can see.
Plaques view, okay. Can you see this thickening of the aortic valve leaflet, thickening calcium and restricted opening of the aortic valve leaflets? Correct?
Yes, sir. Yes, sir.
And this is mitral annular calcification.
Okay.
So we have thickening and calcium thickening, calcified aortic valve leaflets with less opening of the mitral valve leaflet.
Yes, sir.
So first we see always this thickening, restriction of cusp motions, and if you put a colors across it, I don't have a color picture. Let me just see if we have a colors. Then we see a turbulence across this aortic valve, right? What else
Yes, sir.
next?
Sir, then we can calculate the area.
Calculate area how?
Sir, by that equation.
Which equation?
Sir, I can't tell exactly that.
before going to calculation the aortic valve area by continuity equation, we have to measure, we have to go for certain more things. First of all,
sir.
we have to look for LV wall thickness. And how do we look for LV wall thickness? We go for a personal short axis view at aorta and then at tip of the mitral valve leaflets to look for interventricular septal thickness and the posterior wall thickness. If it's more than 12 millimeter in size of the septum and posterior wall in diastole, then we call them as thickened. Because of severe aortic stenosis, majority of time they have a severe concentric LVH or thickened interventricular and posterior wall. Then next issue is what we do. We go to 5 chamber view. This is mitral flow. And then we go to 5 chamber view to look for, this is 3R gradients. This is 3 chamber view for aortic gradients. So we go to 5 chamber view, we go to 3 chamber view, and then put a continuous wave Doppler across this valve to get a peak and mean gradients. Same thing what we'll do in other things, we'll do the same thing out here. Aortic valve, then we trace this aortic valve to get a peak and mean gradients. Let me do an auto. So this is peak and mean gradient tracings. So 4.19, 3.25, 70 and 45. So I'm just going to write it down for you. Velocity is more than 4 meters per second. Mean gradient is 45.79 and VTI is 92 centimeters. This is all what we need from here, right? Then what we do? We go to LVOT. LVOT is where?
Just below the
Just before the aortic
valve.
valve leaflets. So let me just look at an LVOT. So this is LVOT max. So what we got is LVOT VTI is 28.73. Right? And what else you need now?
Lvot diameter.
LVOT diameter. Wonderful. Then we go back to same flax wind view. And this is the most difficult part of aortic stenosis evaluation. We have to have leaflets which are really opened up as much as we can. So I'm going to measure it for you. I'm going to stop it for a second. Then go by frame by frame. When the leaflets are opened up in aortic stenosis, when the aortic valve are maximum open in the mid-systole. So I'm going to get to mid-systole. Now you can say my cursor is at mid-systole now. And the leaflets, now look carefully. Now this is classical doming which is seen over here. Can you see this doming? Right and non-cornic cusp shows doming. Let me increase the gain so that you are able to see better. Can you see this now doming? So this is one hinge point of the non-cornic cusp. This is the second hinge point of the non-cornic cusp. So what we measure with the caliper, we measure from one hinge point to second hinge point. This is 2.4. And this is what is required, the maximum time where we make a mistake. This is the place. So I'm going to do it again for you. Gain, increase the gains so that you can see this. I'm going to stop for you. Now we are almost in early systole. You can see a doming of the leaflets, and I'm going to move a little bit frames by frame so that I've got maximum opening of my aortic valve. So this is one hinge point. This is second hinge point. I'm going to measure it again. Let's see how much I do measure. Is almost 2.4 or something like that. And what we have been teaching now to a large extent is, what we say is you zoom up this picture. So let's play and zoom it up this picture. Run. I'm going to zoom it up for you now. Can you see it better now? So I'm going to stop it for you. Yeah, this is better. Zoom it up. Going to stop it. Move frame by frame to mid systole. So here I am at mid systole almost. Now I start retracting back. So I'm going to measure from one hinge point to second hinge point. This is one hinge point and this is a second hinge point. It is almost 2.4. So number of time I have measured it, this is 2.4 centimeter. So we've got three variables. One variable is Lvot diameter. Second variable is Lvot VTI. Third variable is aortic valve VTI. Is that clear?
Yes, sir.
So how do you do it now? Then let the next person come up and tell me. Dr. Dinesh Tiwari. Dr. Dinesh, are you there?
Yes, sir. Good evening, sir.
Good evening. I gave you three variables for aortic stenosis. What are those three variables?
Sir, Lvot diameter.
Correct.
And sir, Lvot VTI and aortic VTI, sir.
So how do you calculate aortic valve area now?
So we will do it by continuity equation.
Okay.
That is Lvot VTI, Lvot diameter by 2 square into Lvot VTI.
Lvot diameter divided by 2 and square it up, multiplied by Lvot VTI. No. Lvot diameter multiplied by 3.14, that is pi. Pi r square will give you area. Area into VTI will give you stroke volume. Correct?
Yes.
Stroke volume divided by aortic valve VTI will give you
Aortic VTI aortic volume.
Aortic valve area. Is that everybody clear about it?
Yes.
Anybody who's not clear about it?
Yes, sir. Yeah.
So we have got four variables, three variables out of four parts of the continuity equations. We have got three variables. One variable is 2.4 Lvot diameter. So what will be the area? 2.4 divided by 2. That will be 1.2. 1.2 into 2. That is becomes square root of. Multiply by 3.14 pi r square. Multiply by Lvot VTI. Lvot VTI is 28.73. So whatever the values are, I'm going to calculate. Just give me a second. And here the most important thing of this particular phenomena is what? Precise calculation of Lvot diameter. (1.2 into 1.2). into 3.14 into 28.73 divided by VTI of aortic valve, that is 92 centimeters. The area comes out to be 1.41 centimeters square. Is that clear now?
Yes, sir.
Yes, sir.
No, this area is not correct. When the mean gradient is more than 40 millimeters of mercury, we have to go and recheck it again. Okay. So possibly we are doing something wrong with this Lvot diameter. And that's how we come to know. There should not be a mismatch between Lvot area and the gradients at your level. I don't say that is valid for everywhere, but you have to measure this Lvot diameter. So Lvot diameter is by pi r square 3.14 into 1.2 divided by into square of it multiplied by Lvot VTI divided by aortic valve area. That will give you area by continuity equations. Other parameters for aortic stenosis is concentric LVH, then mean gradient more than 40, peak velocity more than 4 meters per second. And where all these parameters, Lvot VTI, Lvot area we calculate by Plaque's window, and then aortic valve VTI and Lvot VTI either in 5-chamber view or in 3-chamber view or in right parasternal window or subcostal window or suprasternal window, and the sixth which you taught you is a right anterior oblique view. And out of these 6, we do not have to do average. Wherever the maximum is, we calculate the gradients, take the maximum gradients across it. Why so? Because aortic valve leaflet is a tri-leaflet cusp. The stenotic jet could be in any directions. And I give you the example. If you pinch a pipe which is sprinkling water in the garden, depending on pinching, the direction of the water can be in any directions. So it's a pinching of aortic valve, the jet could be in any direction, and which we encounter, which we try to do, looking at them in 6 different windows to get the maximum gradients. Any question on this aortic valve stenosis?
Can you show that Lvot diameter measurement on
Again,
any other patient?
I'm going to look at other patients. I do agree with you. Whatever you said is absolutely true, because I was not happy whatever I calculate the aortic valve. And the more calcium is, more difficult it becomes number of times. Okay, I think we'll be better in this. So I'm going to freeze it again. All right. So 1 hinge point to 2nd hinge point. 2 centimeters. Normally area is about 1.8 to 2.4 centimeters square. That was done to be little overestimated as far as I remember, because we were not able to see a clear-cut hinge points. Suppose you cannot do a correct area, then how do you depend on aortic stenosis? Anybody?
The dimensionless index.
Correct. What is dimensionless index?
Lvot VTI divided by AV VTI.
Okay. What is the ratio?
Less than 0.25 is severe.
Less than 0.25. That is considered as severe aortic stenosis. Of course, the only factor in that particular phenomena is we have to get rid of Lvot diameter completely. That's how it works.
What, sir?
we do not consider LVOT diameter in dimensionless index. So in case you have a problem with calculating of LVOT diameter, then answer is you get just for a dimensionless index. That will give you a fairly good idea what exactly this is. Okay. Anything in aortic stenosis more? I've tried to make it as simple as possible, but any question which you want to ask for aortic stenosis?
Good evening, sir. Dr. Samrat here. Sir, I just am a bit confused about the term paradoxical aortic stenosis.
Samrat will be talking about all these things when you come to us with the fellowship programs, you know.
Yes, sir. Thank
But
you,
in
sir.
one line, I can tell you that what is paradoxical aortic stenosis is when we have a continuity equation area less than 1 centimeter square.
Yes,
Then
sir.
we take a gradients across this aortic valve. They are less than 40 millimeters of mercury.
Yes, sir.
Velocity is less than 4 centimeters square.
Yes, sir.
And the stroke volume is less than 35 cc per meter body surface area.
Yes, sir.
So it's a low flow,
Yes,
low
sir.
gradient, severe aortic
Yes, sir.
stenosis. Since there is
Yes,
a
sir.
paradox in the presence of a normal LV systolic function, we call them as paradoxical aortic stenosis.
Yes, sir.
Issue is how this paradoxical aortic stenosis came. The answer
Yes,
has
sir.
been given by two different phenomena, or rather three, I'll say. As the LV becomes hypertrophied over a period of time, the LV starts failing, not able to generate enough gradient across this aortic valve. That's one.
Yes, sir. Yes, sir.
Second answer is because of thickened LV, the stroke volume becomes less. Because if the LV is thickened, the end diastolic volume and end systolic volume difference will not be large.
Yes, sir.
And the third answer given to all these kind of a thing is when we have these kind of a patients, if you look at their global longitudinal strain, their
Yes, sir.
strain is reduced as compared to normal subjects.
Yes, sir.
The GLS is one value which gives you identification of subclinical LV dysfunctions. Only point to remember is they have an absolutely normal LV systolic function. If the LV systolic function is poor, then
Yes,
it
sir.
becomes low flow, low gradient,
gradient.
poor LV
Yes.
systolic function. In those cases, we give a dobutamine in a doses that does not increase the heart rate. It's a positive inotropic support, not the chronic support.
In progress.
Yes, sir.
So we'll
Yes, sir.
discuss all these things when you'll come to
discuss
second
all-
session.
Sir,
Yeah.
Yes, sir. Thank you, sir.
sir, in the measurement of LVOT Doppler assessment, where we will keep the exact sample volume.
Okay, good question. That's what I'm looking forward, man, from all of you. I'm trying to make it as interactive as possible. And I like this. Somebody asked me this question. I really liked it. All right. What's your name, dear?
Sir, Jai Singh.
Jai Singh. Jai Singh, this is 3-chamber view, right?
Right, sir.
So where I'll keep my pulse wave? At the just prior to my LVOT, just prior to aortic valve. Here I'll keep my pulse wave. Let me try if I get a sample volume in this caliper. All right. So no, there's no caliper. Controls. Pulse wave. Unfortunately, this does not have a pulse wave sample volumes, but let me just try to get a cursor. No, it does not have that kind of facilities. Caliper, then exit caliper. So I'll keep my sample volume over here. Can you see my arrow?
Yes, sir, I can see.
So this is pulse wave. Pulse wave is site
Pulse wave.
specific. So
Yes,
I'll
sir.
keep my pulse wave sample volume at this point to take my LVOT VTI. Now in aortic valve, I'll move my pulse wave from here to this point. This to the aortic valve leaflet. What will happen, Jai Shankar?
Sir, for aortic valve, we will kept the CW, no, sir? Or
No, I'll say first we'll keep pulse wave. So once we'll keep a pulse wave over here, this is LVOT, this is aortic valve. In LVOT, I'll get a Doppler spectrum pattern because there is no stenosis.
Okay.
So in continuous wave, we'll come to continuous wave only when we are not able to contain the Doppler spectrum pattern. Correct? So once
Yes,
I keep my pulse wave in this, what will happen? There will be so much of aliasing will
Eliza.
happen.
Yes, sir.
So how do you adjust aliasing? By increasing the scale and moving the baseline up.
Okay.
Even then, we are not able to contain the Doppler spectrum pattern. And then how we switch over to continuous wave Doppler.
Okay, right, sir.
The continuous wave Doppler will take a velocity of LVOT as well as at aortic valve. So we are not bothered about the LVOT. We are bothered about aortic flow velocities. So pulse wave at LVOT and a continuous wave at aortic valve to look for aortic valve VTR.
Or in 5-chamber view, sir?
Same thing in 5-chamber view. Suppose this is a 5-chamber view, so we'll be at LVOT and aortic valve. And
will you show, sir, once
5-chamber
like this?
view, just let me look at a 5-chamber view. In case I've got one, I'll show you. So it's opening a little bit. Let me just freeze it for you. No, I can't say you because this is like if it's aortic valve, I'll keep my sample volume over here in 5-chamber view and then do a continuous wave Doppler across it. The aorta is not open up over here, so I don't have a picture for aorta opening up. In some other window, when I will see a 5-chamber view, I'll show you at that time immediately.
Okay, sir.
Okay.
Okay.
And
sir,
with this aortic valve, we do in 6 different windows. I'm saying it again and again. 5-chamber, 3-chamber, right parasternal, subcostal, suprasternal, right anterior oblique view. 5-chamber, 3-chamber, you all of you know very well. Subcostal, you know very well in subcostal. Now look at in this subcostal window. This subcostal window is RV, RA, LV, LA. If your footprints start looking towards aorta in subcostal window, what will happen? The aorta will open over here. And you put a sample volume across it by continuous wave Doppler, you get an aortic valve gradient. But make sure that aortic valve gradient is not interrogating this tricuspid flow. So let's leave it a 5-chamber and 3-chamber for all of you. That'll be reasonably fine. If you do it, that'll be more than enough. Okay. Now
okay,
I'm
sir.
going to measure this aortic valve Lvot diameter better in this particular image. Just give me a second. Now you can see a very good opening of aortic valve leaflets. I'm going to reduce the gain a little bit. Can you see this right coronary cusp moving over here? Non-coronary cusp has got a lot of calcium in it. So let me freeze, stop, then move frame by frame. Great. So this is one hinge point. This is second hinge point. So let me do a caliper. Wherever the insertion of leaflet is happening, it's 2.2 roughly. At this point, many people, they may say that this is not LVOT because they say the LVOT you have to measure 3 to 5 millimeter inside. So that is how you go to 5 millimeter this side, 5 millimeter this side, and then join this line to get an LVOT. It's almost same. So you can take a hinge point. Some people of you might be, no, that's not, this is a annulus. This is not LVOT. So we go 5 millimeter inside into the LVOT on either side and join this line to get LVOT dia. Is that clear, dear? Any other question for aortic stenosis before I move to MR and AR?
Sir, can you show something about subvalvular and supravalvular aortic stenosis continuous wave patterns?
Supravalvular and subvalvular aortic stenosis. Okay. Give me a second. I'll try to find it out. Give me a second. I'm trying to find it out. Yeah, I've got a subvalvular. What is subvalvular LVOT? Subvalvular aortic stenosis. When you have either a membrane or significant LV hypertrophy at the level of LVOT. Right?
Yes, sir.
So I'm going to show you one. Can you see the slides now?
Yes, sir.
Yes.
All right. Give me a second. It's trying to play now. Not this. Now look carefully. Here is the aortic valve, right? And look at this LVOT, which is being over like some kind of an obstruction seen over here. Before an aortic valve in LVOT. If I put my continuous wave Doppler, look where the turbulence is. The turbulence is right over here. Just before an LVOT. And if I put my continuous wave Doppler, look what is the two kind of a Doppler spectrum pattern which are seen in this. One is like coming like this, and second is of aortic stenosis coming like this. Another good way of showing this is, I'll just freeze the frame for you. As the aortic mitral valve open, this AML touches LVOT, interventricular septum thickness. Now look carefully. So there is a potential obstruction to aortic valve flow.
Yes.
And what you get an inverted key slope shape pattern, which is known as dynamic LVOT obstruction. You can see this inverted keystroke shape pattern.
Yes, sir.
This is at LVOT. And this is aortic stenosis. So this patient was not only carrying an LVOT obstruction because of significant LV hypertrophy, but also was having a severe aortic stenosis. The gradient is almost 4.5 meters in suprasternal window.
Yes, sir.
And the patient was having both aortic as well as subvalvular stenosis.
Both components. Yes, sir. Thank you.
Supravalvular, I'll show you. Like, I think I have one supravalvular. I just took it out about, no, supravalvular, it was in aortic, not in aortic stenosis. All right, any questions about aortic stenosis further?
Sir, Jigna here.
Jigna, go ahead.
Sir, for LVOT VTI, so normal ranges for LVOT VTI is for what?
Normal velocity is up to maximum. How much is the velocity? 1.5? 1.5 into 1.5 into 4. 2.5, 10.
10. Okay. For LVOT obstruction, we consider above 20, sir?
About 25.
25. Okay, sir. And so for LV hypertrophy, do we need to take a direct measurement of septal IVS and posterior wall, or sir, we need to consider index value, sir?
No, we don't have an index
LV
value
mass
for
index?
these dimensions. We
LV
have
mass
only
index.
like various views are there. American Society of Echo says more than 10 millimeters.
Oh, there.
And if we consider 10 millimeters, almost everybody in India is hypertrophic.
Yes, sir.
So what we do in our lab is we consider 15 millimeters of size of LV hypertrophy in diastole. Because systole will be thickening automatically. At least we consider as 15 millimeter. Book says more than 12.
Okay, sir.
So we consider almost 15 millimeter in LV hypertrophy.
Okay. So LV mass index, we don't consider LV mass index.
Jigna, now you're going to level 2.
Okay.
You are looking for RWT, LV mass index, and LV IDD.
Yes, yes, sir.
So
Yeah,
let's. I know you know the subject. Let's hold it
yes,
over
sir.
here.
Okay, sir. Yeah.
Right.
Yeah.
In those cases, you look for concentric, eccentric, concentric
Yes,
remodeling,
sir. Yes, sir.
as well as normal LV. We are not going to discuss all these things at this level.
Okay. Yes, yes, sir. Okay. Thank you,
Okay.
sir.
Right.
Yeah.
Anybody else?
Sir, is it the thickening of posterior wall or septum?
Anupa, speak a little loudly.
Sir, is it thickening of posterior wall at 15?
Both septum and posterior wall, about approximately 15 millimeters. But you can consider anything more than 12 is abnormal.
Okay, sir.
I know there's a lot of discrepancy in this. Some people may not like my sentence, but that's how I say that. And truly speaking, nowadays I don't look for LV wall thickness. I look for what Mrs. Jigna Viresh was saying. We look for a parasternal short axis view at papillary muscles. Then we look for LV IDD. Then we look for relative RWT, relative wall thickness, and then we go for a concentric mass, LV mass. 95 versus 42. That's how we come to. That's not at your level. At your level, just consider posterior and septal more than 12, and for guaranteed 15 millimeters of size of thickness. All right. Anybody else question? Tamogna Das, no questions?
Sir, sir, I had a question, sir. Is there any role of planimetry in case of aortic stenosis?
There is a role of planimetry in aortic stenosis, but not in transthoracic, transesophageal. Because whenever we measure transthoracic echocardiography, this planimetry, we were not able to correlate with aortic valve area when we were doing surgery and other things. The correlation has been very good when we were doing a aortic valve area by planimetry in transesophageal.
Okay, sir.
Tamogna, you have some question?
Yeah, sir. This is the question I had, sir.
Okay.
Sir, I have a question, sir. Majorul Islam here.
Yeah, Islam, go ahead.
Sir, valvular or sir, subvalvular, which one is sir most common type in aortic stenosis and which one is severe, sir?
Look, aortic stenosis is valvular only.
Yes, sir.
When we talk of subvalvular, this is not truly aortic stenosis. Sub means before.
Yes, sir.
Supra is after valves.
Yes, sir.
Subvalvular aortic stenosis you can find in concentric LVH, thickened LV,
Yes.
or asymmetrical septal hypertrophy like in HOCM. Right?
Yes, sir.
But truly, when we talk of aortic stenosis, we always talk of valvular aortic stenosis.
Valvular aortic stenosis. Okay, sir.
Okay. If everything is fine, let me move on to next. My topic is regurgitations. I hope you guys are not tired. Nobody's speaking, you know.
No, sir, not tired.
Everybody
No,
appears
sir.
to be
Not
tired.
tired.
You know?
No, sir.
No, sir. Good. Even if you're tired, don't say that I'm tired. So let's move on to mitral regurgitations. So the question goes to look that these are tip and tricks of your day-to-day practice. Dr. Bhimrao Pawar, Bhimrao Roop Singh Pawar, B.R. Pawar. Pawar, are you there? Dr. Rakshit Bhardwaj. Dr. Pawar.
Yes, sir.
Tell me, how do you assess mitral regurgitation? नहीं पढ़ रहे डॉक्टर पवार, you're not reading.
सर मेरी शादी हुई है सर जस्ट परसों, तो उसकी वजह से नहीं पढ़ा।
अरे आपने मिठाई तो खिलाई नहीं डॉक्टर पवार, अब कैसे पता लगेगा कि आपकी शादी हो गई?
नहीं सर, अभी जस्ट परसों ही शादी हुई है, इसलिए मैं थोड़ा busy था।
No, 100% excuse. We are not going to ask you any question for next 3 months.
Thank you, sir. Thank you.
God bless you, Pawar. Take care of yourself.
Thank you, sir.
A lot of wind blowing ahead of you, you know.
Yes.
Dr. Rakshit Bhardwaj. Rakshit. Dr. Ankan Patel.
Yes, sir. So for mitral regurgitation, sir. So first we have to see, sir, whether the left atrium is enlarged or not, then left ventricles are enlarged or not. Then, sir, if there is any vena, sir, then we have to measure the vena contractor, sir. Then, sir, we have to see the jet area, and we have to calculate the regurgitant volume, sir.
All right. We have said so many things in one go. So what we look in mitral regurgitation is, as he said, we always look for LA dilatation. LA dilatation could be because of mitral stenosis, it could be mitral regurgitation. Then second is, what we look in mitral regurgitation is, go to four-chamber view. We look at what?
Vena contractor.
Vena contractor.
Vena contractor is not in four-chamber view, dear.
Flax vena contractor.
Flax view. So let's go to vena contractor first, because even I like a vena contractor a lot. So let me go and show you the vena contractor. Vena contractor would be seen in systole or diastole?
Diastole, sir.
Diastole.
Vena contractor in diastole.
Systole.
For MR.
Systole,
You will
sir.
kill me, man.
Systole.
In systole.
Yes.
When LV is contracting, then only you will get a vena contractor, gentlemen. Don't do this thing again. Thanks God my colleagues are not there today. So not a good vena contractor which is seen over here, but I'll show you a vena contractor. Give me a time. Before vena contractor, what we look is, we look for
Jet area.
jet area versus LA area and jet area. So jet area would be seen in systole or diastole?
Systole.
Always in systole, sometime in diastole also.
Systole, sir.
Always in systole.
This is beautiful. So look at the cursor. This is in systole, right? So this is jet area what we trace. So I'm going to measure the jet area. Trace this jet area. .9 centimeters square, and this measure this LA area. This is 15 centimeters. So let's presume this as 16. Let's presume this as 4. This is only 25% of the area of LA. What do you say, this mild, moderate, or severe? By jet area is 4.
Mild.
And by jet area versus LA area? 25%, 4 and 16. So again, it's considered to be mild.
Mild to moderate.
I don't know what is moderate, but whatever we are doing it right now with that method, it comes out to be mild. So does this look mild? I don't think it looks mild. So that's what I was trying to tell you when I was teaching about mitral regurgitation. This regurgitation, if you look at this area, this is only one direction we are looking at the area. The jet could be posteriorly directed jet or anteriorly directed jet. Second, the jet is dependent on LV contraction and LA pressures. The jet is dependent on high blood pressure or a normal pressures. So this area, by looking at it, will say mild, but the perfect method of looking at this area for regurgitation is when we look for vena contractor. So I'm not able to show a vena contractor in this. So I'm going to switch over to other patients where I could show my vena contractor. This is more than vena contractor. All right, I'll give you a little. Let me just show you something different. This is too much of a vena contractor for all you. Wonderful. Yeah. So let me hold on this clip for you. Stop. Now concentrate on this. This is end of a systole. So I'm going to go to diastole. Sorry, end of systole. I'm going to go to mid systole. Wherever I'm going to get a best jet for MR. Now, if you look at carefully, this is the origin of a jet between two leaflets, but this is eccentric jet. So we have taken another view where this is not a live clip, but certainly we have measured the vena contractor. So we moved a space up to look for a jet between two leaflets of the aortic mitral valve. First, I'll get rid of this CFM. Now, This is a place between two leaflets where we are measuring the flow of a color during systole in plaques window. Once you switch on the colors, we measure from this point to this point between the two leaflets of mitral valve leaflets. 0.7. Are we clear what I am trying to measure is? Anybody who is not comfortable can come up, because this is most important part for any evaluations. This patient has got multiple ectopic activity also. I'm going to stop at this for you. Let me move by frame to frame. Whether I'm able to get a good vena contractor in this or not. Yeah. So this is, no, this is forward flow. This is not a regurgitant flow. So this is the best I could show you over here. This is known as vena contracta. So if this vena contracta is more than 0.7 centimeter, we consider it as severe mitral regurgitations. What are the other features for severe mitral regurgitation is? We need to look at LV. LV has to be more than 32 cc, 32 millimeter per meter square body surface area to call them as dilated LV. So when we talked of these things, we said couple of things. One was LA size, which is dilated. Second was the jet area versus LA area and jet area per se. Then we went to vena contracta, any vena contracta more than 7. Then LV internal dimensions during diastole more than 32 cc per 32 millimeter per meter body surface area. And of course, we did not talk about this PR jet gradients, but these are the few things which we need to look at mitral regurgitation. And amongst all these things, the most important part is the vena contracta. Then, like once you have to do an LVOT, it's the same way you have to do a vena contracta in this subset of populations. Any questions about this MR? I'm trying to look at like how simple I can really make it. Any questions? Somebody has got it?
Sir, hello.
Yes.
Sir, I want to know whether we are missing this green color as regurgitant jet or that blue color.
Who's this? Jigna or
Anuba?
Anuba. Anuba, what happens? Now your question will be given by you only. When the regurgitant jet happens, the LV gradient, LV pressure is 120. LA pressure is only 10 millimeters of mercury. The gradient between LV and LA is 110 millimeters of mercury. So what will happen to this Nyquist limit? It will show turbulence. And that's why the turbulence is, we call them as high gradient flow across this regurgitant flow. Your question is whether this blue or whether this green. I said all of them. Look, let me increase the gain. Now you'll see what happens. I'm increasing the gains now. What happened to MR? Increase or decrease?
Increase.
Increase. So at the time, now when I was increasing the gains, these were a lot of colors which were seen. The garbage color was seen. So I'm going to reduce so that you can see a no garbage. So in this patient, let me stop and show you the two jets which are seen over here. First jet is during diastole. So this is a mitosynotic jet. So I'm going from, this is all mitosynotic jet. Can you see this?
Okay, sir.
And now I'll go show you the regurgitation jet. This is systole. These are regurgitant jets. There are more of them. And second important thing is we are only looking at one section. We are not looking at three-dimensional picture.
Okay, sir. Sir, whether this green color or this whole blue color we have to measure for assessing jet area?
All have to measure. If I have to measure, this is not a correct measurement which I'm going to do for you, because I'm not able to see a full color jet. If I have to look at a full color jet, I'll make my image a little oblique so that I'll be able to see complete jet flow. The same thing I was trying to show in that image earlier. Now this patient, this is 3-chamber view. Now in 3-chamber view, now let's see that the jet is eccentric. Can you see this jet now? Same patient?
Yes, sir.
This is the jet over here. And this jet is not up to this point. Now look carefully, go back. Can you see this jet going down all the way?
Yes, sir.
So it's very difficult to measure this jet area. Now in the playing list, you can see the jet is going all the way down and is swirling back in red color, coming back to mitral valve. So this jet is a huge jet, which we are trying to see in one dimensions. And that's why we do not put a lot of emphasis unless until we have to really, like, if you ask me how to look for mitral regurgitation, believe my words, I'll never ever look at this MR jet area versus L area. In my class, when I'm talking of level 2 or level 3, I'll talk of vena contracta, LV dimensions, then I'll talk for regurgitant volumes, and then PISA method, which I'll employ in these sort of populations.
Okay.
What you can do in this population is, suppose you do not have any mitral stenosis. I gave you that one answer, mitral aortic velocity integral ratio, MAVIR. What is the blood which is flowing through mitral valve has to flow through aortic valve. If you look at the VTI of mitral valve and a VTI of aortic valve, if the ratio is more than 1.4, then you consider safely that these people have got a severe mitral regurgitation. Why is that? The amount of blood which is flowing through mitral valve would be 1.4 times the aortic blood flowing through the aortic valve. So where is the blood rest going? 0.4% blood is going back into the LA. That is constitute to almost 40% of a regurgitant volumes.
Okay, sir.
So at your level, best concentrate in plaques window, the vena contracta. If you happen to find it more than 0.7 centimeter, then you start looking for other things, like whether the LV is dilated or not dilated. And then you start looking for jet area in this particular phenomena, and still look at the MAVIR, ratio of mitral aortic flow velocity integral ratio. And finally, if you really can do it, you can look at the stroke volume at mitral wall. You look at the mitral annulus in 4-chamber view. You look at the aortic at LVOT annulus. You look at a mitral flow. You just put a like this. You get a TVI. Suppose you got a 4-chamber view. Here you are able to calculate the mitral annulus. So mitral annulus would be in diastole. So systole, and now I'm getting the maximum size in diastole.
Yes.
Caliper, this is my mitral annulus. This is 4.4. Then from this, I'll drive my area, pi r square, to 4.4 divided by 2, 2.2 into square of that into 3.14. And then I got a mitral flow velocity integral ratio. This is VTI, 73.76. So 2.2 into 2.2 into 3.14 into 73.36 is the amount of blood which is flowing through mitral annulus. Is that right?
Yes, sir.
Same thing now you look at LVOT. So this will be a stroke volume at mitral valve. You look at the stroke volume at aortic valve, LVOT. The difference between those stroke volume would be your regurgitant volumes. Okay, little cumbersome at your level, but this is what we do in our lab when we are in trouble.
Okay, sir. Thank you.
Anybody, any other questions before we go for aortic regurgitation?
Sir, can you please repeat about MAVIR?
MAVIR is nothing else, mitral aortic velocity integral ratio. Mitral aortic velocity integral ratio. What we have done is, we look at a VTI across mitral valve, we look at the VTI across aortic valve. If the ratio of mitral versus aortic is more than 1.4, then we consider a severe mitral regurgitation. Why is that? The amount of what is velocity time integral? Velocity time integral is the distance the blood travel in one stroke is VTI. The blood which is flowing across mitral valve would be more as compared to aortic valve when we have severe mitral regurgitation.
Yes.
Is that clear?
Yes, sir. Yes.
So next move on to question of aortic regurgitation. These are just practical. How do you do it? Dr. Ankan Patel and Nitin Gupta.
Sir.
Ankan. Tell me the features of aortic regurgitation.
Sir, we have to see that the left ventricle enlargement is there, not sir.
Okay.
And sir, then sir, we have to go to the color Doppler, sir, in 5-chamber view.
5-chamber view, color Doppler straightforward. No. Again, the most common part of any aortic regurgitation is, we told you, jet width height oblique LVOT height.
Sir.
And vena contracta, holodiastolic reversal of flow in descending aorta.
Sir.
So let me show you one by one. This is a complete study which we do in our lab. Like nothing is left when we are doing work. We have measured LA. LA is 16.29 normal size. More than 20 is abnormal. Then we measured LV, 26.28 millimeter per meter body surface area. Again less than 32, normal in size. Pulmonic flow velocity, mild pulmonary regurgitation is present. We're not concerned about that. Look at this LV dimension. This is normal and LV looks to be reasonably good contracting. Not a very good window to show that, but it is reasonably a good contracting. We can vouch for it. So now you can see 2-chamber better than before. First 2-chamber was not good. This was bad. And this is a good 2-chamber view, which we see. So LV function appears to be reasonably normal. Then we look at the flow across this mitral valve. Let's look at the flow across this mitral valve, E and A wave. And intermittently you find this AR jet. Then we E prime septal, E prime lateral, and then LA volumes. So we have completed our rest of the work before coming to aortic valve. Now this is aortic valve. And now in aortic valve, you see this regurgitation pattern. So flow velocity across aortic valve is 1.88, mildly increased. We do not call this as stenotic valve because this flow velocity could be increased because of aortic regurgitations. Then we go to tricuspid, TR jet gradients, and then this time now we are done. Now we'll start concentrating on aortic valve. LV function first. That was 4-chamber again. Nothing to bother about U level at this. No, we do not have the much needed AR. Let me just go back another slide. So it's just a trivial AR patient was having. I'll have to find out a bigger one. Yes. Very classical picture of this patient as severe aortic regurgitation. Anyway, let me show you all the features before I show you a clip of AVI. Now look at his LV. LV appears to be little thickened, 14.72 of interventricular septal thickness in diastole, and LVI posterior wall is 17. So the concentric LVH is present over here. On top of that, look at the LV dimensions, 34 and 22. So this internal dimension during diastole is more than 32 millimeters per meter body surface area. Then it's dilated. Then we went on to do a vena contracta. Vena contracta is same thing as we do in mitral regurgitations. So I'm keeping two windows. Hopefully I'm able to show you two windows. Just give me a second. All right. So these two windows, one of the window, no, it's gone. So this is vena contracta from where this jet valve originates. So I'm trying to show you this vena contracta. This is a point of vena contracta from the where the jet valve regurgitation jet originates. So this is vena contracta, and we can measure this vena contracta from the one point to the second point. So this is vena contracta, which is almost 0.7 centimeters. Severe aortic regurgitation. That's one point. Second point is I have to measure now jet width at LVOT. So vena contracta was somewhere here. This is the valve leaflets of the LVOT. So we measure the jet width at LVOT. So I'm going to measure the jet width at LVOT. So this is the jet width at LVOT, which is 1.4 centimeters. Now I have to measure my LVOT diameter. So here is LVOT diameter. And you can see this is one point of LVOT diameter. This is second point of LVOT diameter. And this is a jet width. Vena contracta is somewhere over here. So this is first is 1.16. That is the vena contracta in this view. 2.68. This second is LVOT diameter. And third is jet width height oblique LVOT height. This is 1.38. So if we consider this as 14 and consider this as 27, this is almost 50% of the jet width is being occupied in LVOT. And vena contracta is more than 0.7. With LV dilated, with these parameters, we come to almost conclusion that these people are possibly having a severe aortic regurgitation. One is jet width. Second is jet width oblique LVOT height. Third is vena contracta. Fourth is LV dilatation. What else? Majority of people we always do is, what we do is pressure half time. Let me show the pressure half time of aortic regurgitation, because that's what majority people they like to do. So this is aortic flow velocity. This is pressure half time. And we measure the pressure half time from this point to this point. So this is a point of pressure half time. We drop down to this. This is almost what? 336 milliseconds of pressure half time. We could have one good window. No. Then last point is to look for holodiastolic reversal of flow in descending aorta. Now this is an arch. This is ascending aorta. Here is a descending aorta. So you can put a cursor. First of all, we see a lot of red color going back into the arch and ascending aorta. Reversal of flow is seen out there. So what we do, we just put a cursor, M mode. Yeah. So what I did, I put a cursor into this mitral aortic flow pattern in descending aorta. So if you look at carefully, this is what the systolic part is there, the blue in color. And this is all diastolic part of reversal of flow which is present. So with this, we can definitely say this is holodiastolic reversal of flow in descending aorta. Holodiastolic means through whole of a diastole. Here, the end of a diastole, here is the beginning of diastole. So we can see a color flow in whole of diastole. And same thing we can see in, I think we have done in this next frame. Look, we have done in this next frame also the same thing which I showed you. So we could see this systolic flow and we could see this diastolic flow in holodiastolic. And if you put a Doppler spectrum pattern across this descending aorta, this is systolic forward flow and this is holodiastolic reversal of flow in descending aorta. And now the next question comes, if I measure this, let me trace, let me go to generic, trace. If I trace this from this point, go up all the way down. Look at the VTI. How much is the VTI? VTI is 25.6 centimeter. First of all, let me just take a heart rate. So VTI in this patient is 25.6 centimeter. Any VTI more than 22 is considered as abnormal. Then we take a end diastolic velocity. Caliper is, we put this at end diastolic velocity. End diastolic velocity is 32 meters, 0.32 meters per second. So any velocity more than 0.22 meter per second is considered as severe aortic regurgitation. So what are the things which you always look in aortic regurgitation is, I said you first, we look at LV dilatation. We had LV dilatation. Second is, we look at a vena contracta. The vena contracta was almost 1.6 centimeter. Then we look at a jet width height oblique LVOT height. Here is a ratio which is almost more than 50%. And then we look for a holodiastolic reversal of flow in descending aorta, which we did saw the holodiastolic reversal of flow in descending aorta. So this is holodiastolic reversal of flow in descending aorta. We look at a holodiastolic by putting a color M mode over here and looking at whether it's whole or diastole or not. And then we measure the Doppler spectrum pattern. I just showed you that VTI more than 22 and end diastolic velocity more than 22 centimeter is considered as abnormal. So these are the 5 or 6 parameters with which we utilize this. And pressure half time is another one. When it is less than 200, more than 400, when we classify them as severe versus normal in aortic regurgitation. Whether it's mitral, whether it's aortic, always vena contracta play a significant role. Vena contracta of mitral regurgitation would be in diastole and of aortic regurgitation would be in diastole. So you'll have to spend time in both these views, and both MR and AR, you have to have LV dilatation. In MR, we had LA area versus jet area. Here in AR, we have jet width height oblique LVOT height. And the most important crucial point is, you must have seen in your clinical times, when we talk of a run of a pulse, water hammer pulse, then collapsing pulse, the most important thing of aortic regurgitation. And believe my words, even today also, if I'm looking at somebody as a severe aortic regurgitation, I always take his blood pressure. The wide pulse pressure is important. If there is no wide pulse pressure, then your diagnosis of aortic regurgitation is very, very wrong. This is all I have to talk about aortic regurgitation. Nothing significant. I have not talked so many things today, but basics I'm able to tell you what is aortic regurgitation is. So let me go by one who are left, and anybody then after I'll ask people if they have some questions, then we'll go for hand. I'm not able to take today my pulmonic stenosis and regurgitation. I'll take quickly whenever I have time in next of my classes. I'll do complete it whether it's regurgitation or stenosis in pulmonic valve. So let me go back to now my 17 number person. Dr. Nitin, you have any questions? Nitin, are you there? Hiru Alamin?
No question, sir.
Dr. Sirisha? I know everybody must be tired now. Ganesh Tukaram Thomre? Sayali Nandkumar Bangre? How many people are left? Only few of them are left now. Anyway, let me just put attendance to everybody. I'm not going to say no to. Any questions somebody has got it, just let me know. Anybody has got some question before I close it over here?
No questions.
Sir, Dr. Tamogno here.
Kevin, go ahead. Tamogna, you go ahead.
Yes, sir. Sir, what is the best view to see the holodiastolic reversal?
Suprasternal window.
Okay, sir.
Kevin?
No questions, sir. No questions.
Dr. Yogesh?
Did you tell Durgesh or Yogesh, sir?
I said Yogesh, but Durgesh
Okay.
can also ask my question.
No,
Hello.
sir, no questions. Just about the attendance.
Attendance is
Most of the
done,
questions
Durgesh.
were
No questions, sir. No questions.
no
sir.
questions. No questions.
So all are done with the questions, man. No.
Yes, sir.
It's too much of a tiring today.
4 legions together.
Multivalvular lesions, you know. I know it's difficult, but it's like whatever we have taught today, like I could teach you, that gives me a really a satisfaction that at least I am able to cover those things. Rest will only come when you will start doing a hands-on,
Hands-on.
because that is the most important thing in hands-on times. So if there are no more questions, let me say you goodbye. Take care, stay safe, and get ready for the next week.
Attendance you have taken, sir.
Pardon? Attendance,
Sir,
I have
attendance
clicked
you
your
have taken.
photograph, Majrul.
Yes, sir.
I have clicked your photograph.
Yes, sir. Thank you, sir.
But I can quickly finish it off. If everybody is ready, I'm able to finish it off quickly. But I'll mark it only. Don't worry about it. Okay, let me say thank you very much and get ready for the next week questions. I'll not ask question from a pulmonic stenosis or regurgitation. But rest, obviously, we are going to ask question from mitral stenosis, aortic stenosis, tricuspid stenosis. At least we'll ask these questions.
Sir, what about TR, sir?
Tricuspid regurgitation, we have taught about it, but we'll be teaching it about adjusting again. Tricuspid regurgitation is the same thing. We look at a 4-chamber view or a modified 4-chamber view or focused RVRA view. We look at a vena contracta and tricuspid 4-chamber view itself, the amount of blood which is flowing through the tricuspid valve. That is vena contracta. And recently this vena contracta has been modified as mild, moderate, severe, massive and torrential. Anything less than 7 is considered as moderate. Less than 3 is mild. 3 to 7 is moderate. More than 7 is severe. Then 1.1 is considered as massive, torrential, and then more than 1.4 is considered as torrential. That does not make any difference. But ultimately, you have to get a pressures across it. What is the pressure of TR jet gradients? We'll be coming back to them again and again. We did talk about this pressure gradient during our initial periods, but we'll be coming back to them again and again.
Okay.
Sir,
Yeah, Dr. Nida.
sir, there are two formulas to calculate regurgitant volume, sir, in MR. First is stroke volume of MB minus stroke volume of LVOT.
Okay.
And the direct method is stroke volume of LVOT minus stroke volume of MR volume, LV stroke volume minus aortic stroke volume.
No. First of thing is we take a mitral flow stroke volume at mitral annulus and aortic annulus, LVOT annulus. Let's understand there's a four-chamber view. In four-chamber view, we look at like I showed you that calculation of mitral annulus, and then we calculate mitral flow VTI. Mitral flow VTI into mitral valve area will give you stroke volume across mitral valve, right?
Yes.
Then we go to LVOT. We get LVOT diameter and LVOT VTI. They'll give you a flow across LVOT flow.
LVOT.
In the case of normal aortic valve, so whatever the blood which is flowing through LVOT has to flow through aortic valve. So normally in cases where mitral and aortic they are normal, whatever the blood of flow which is happening through mitral valve has to flow through aortic valve. Now in mitral regurgitation, the volume of blood flow at the mitral valve would be much more than the volume of blood which is happening at LVOT. Is that right?
Yes, sir.
So mitral flow minus aortic flow will give you indirectly a mitral regurgitation volume of across mitral valve. That's one way. Now the second way is you take an end diastolic dimension of LV, you take an end diastolic dimension and systolic dimensions of LV. End diastolic volume minus end systolic volume is what is? Stroke volume across aortic valve. Now you come back to into mitral valve. You look at the stroke volume across mitral valve. So stroke volume across mitral valve minus stroke volume across aortic valve will give you the regurgitant volumes. And believe my word, the first formula of mitral annulus calculation along with mitral valve VTI minus LVOT VTI and LVOT area volume, that is much more correct rather than the stroke volume of LV, because LV is dependent on our measurements, because end diastolic volume minus end systolic volume. That is what we trace. Here we are not tracing anything. So this formula, first formula, is more appropriate rather than the second formula. All right, Nida?
Yes, sir. Yes, sir.
Anybody else? All right, take care. Let me say you good night. Shabba khair. Stay safe. See you next week. Get ready for question answer sessions. Bye-bye.
Good night, sir.
Good night, everybody.